And we are live. Hello, everyone. Welcome to Uqora's AMA session in partnership with My UTI. My name is Olivia. I'm part of the brand team here at Uqora, and I will be your host for today. This Friday, November 21st, is National UTI Awareness Day, an annual moment that Uqora established in 2020 to recognize the millions of people impacted by UTIs and urinary tract health, and to offer real support. Fun fact, National UTI Awareness Day actually started as an idea from a Uqora customer. After finally feeling understood and supported, she felt UTIs deserved recognition, national recognition, and we couldn't agree more. That's why we're here today. If you've ever felt like your UTIs were no big deal to everyone but you, this AMA exists for you. Uqora exists for you, and we're here with science-backed products, expert-led education, and a community that truly gets it. A couple of housekeeping items before we dive in. We've collected questions in advance from the Uqora Collective Facebook group, and for those of you who submitted via the event page, we've got yours in as well. We will start with those questions and then open it up to all of you watching live. So please feel free to drop your questions in the chat as we go. If you have product-specific questions, we have two wonderful, wonderful helpers behind the scenes, Mary and Autumn. They are at the ready, waiting for your questions and ready to help. Now, I'm thrilled to introduce my co-host for today's session, Megan Henkin, co-founder of My UTI. My UTI offers advanced at-home lab testing for urinary and vaginal health using PCR-based tests that can identify multiple pathogens and antibiotic resistance. Their goal is to give people with recurrent or complicated UTIs clear answers and treatment guidance that they can then take back to their care team. So, Megan, welcome. We're so happy to have you here.
Thank you for having me.
Of course. And now, for our guest of honor, Dr. Milhouse. Also known as Your Favorite Urologist, she is a board-certified urologist and a specialist in female pelvic medicine and reconstructive surgery. She's based in Chicago. She's a Healthcare Impact Award winner from Top Docs and was named the top urologist in Chicago by Women in Medicine. You may also recognize her as the star of TLC's Doctor Down Below. Of course, this is only the tip of the iceberg. Let's get her on here for a proper introduction.
Hi.
Thank you so much. It's an honor to have you here today. We're all so excited. Thank you for sitting down with us.
It is my pleasure.
To kick things off, I know I just gave a very, very quick intro, but I'd love for everyone to hear more from you and in your words. Can you share a little bit about your background, your practice, and what drives you to do this work?
Absolutely. So thank you for having me again. I enjoyed talking about UTIs, believe it or not. So I am a board certified urologist. That's a specialist. That's a surgeon that is trained in the urinary tract, among other things. And I did a fellowship in what is essentially urogynecology. So after residency in urology, I did extra training in things that affect primarily women in their vulva, vagina, and urinary tract. And one of those things includes recurrent UTIs. I barely saw recurrent UTIs in residency. It just is not really a core part of most urology residencies because we're learning about cancers and major malformations and stones and this and that. So I saw maybe 5 patients with recurrent UTI in residency, and then in fellowship, multiple patients, and learned about the power of vaginal estrogen and other things that we'll get into. And when I got in practice, I saw tons of recurrent UTI patients. And I'll tell you, at first, I was resistant to this. I am a trained person. I want to do surgery. And then I embraced it because so many women suffer. And as a woman myself, I can relate to suffering I had myself. And so I embraced it and like kind of labeled myself the UTI queen. And I own my own practice now. In Chicago, and UTIs are a major part of my practice, and I'm really advocate for patients struggling with UTIs. I became a patient who had UTIs myself, which really adds a deeper level of empathy and understanding and patience, and made me reevaluate my own processes now that when I started struggling with recurrent UTIs when I turned 40. So that is my kind of intro into why I'm so passionate about what we're talking about today.
I think I speak for both Megan and I that we've we've also been there, and the toll it's brutal.
Yeah.
I'm gonna roll into the questions if that's all right. Get things moving and grooving.
Let's go.
First question. For someone who keeps getting UTIs over and over, how do you approach figuring out and addressing the root cause instead of just prescribing another round of antibiotics?
Okay, so first of all, I am an antibiotic steward. That means I want to use antibiotics conservatively. I want to avoid overusing antibiotics because we live in an antibiotic happy medical world. We have growing antibiotic resistance, multi-drug resistance. I've seen it. I see it all the time. So I'm an antibiotic steward. If you come see me, the last thing I'm going to do is knee-jerk antibiotics. Okay, number one. Number two, the root cause. Everybody's like, well, what is the cause? What is the cause? This is where I have a sit down with the patient. I say, you know what? We don't know exactly why one woman versus another woman is more susceptible, but women, biological women, we are more prone to UTIs. Anatomically, our urethras are shorter, significantly shorter than penis owners. And so we have a higher risk. As we get older, that risk goes up. There are other certain things like sexual intercourse that increase our risk. 1 in 4 women have recurrent UTIs. Okay. 1 in 4. All right. So oftentimes what we have found, and I used to do a workup on every recurrent UTI patient. Every recurrent UTI patient used to get a cystoscopy where we looked in your bladder and a kidney ultrasound or CT, all like for years. Okay. And actually, I can't remember the exact year, but I think maybe it was 2020. Don't quote me. The American Urologic Association guidelines came out regarding recurrent UTIs in women, and they basically said these tests rarely show an abnormality. And as a urologist, I can concur. I almost never found abnormalities in people's kidneys or bladders. They rarely show it, and so therefore, we don't need to knee-jerk do these tests for the initial workup for recurrent UTI in women. All right. So the root cause is most likely you're just the unlucky 1 in 4. You got it? You see what I'm saying? You're just the unlucky 1 in 4. If you're postmenopausal, add that, sprinkle that into it. That's a cause. Okay. So I have this, I explain this to patients so they feel better maybe about the fact that they're not anatomically broken most likely, and 2, they aren't causing the UTIs to come on themselves. We can talk about behaviors, we can get into it, but most of us aren't doing behaviors that are purposefully causing these.
Kind of a follow-up to that. If someone has needed multiple antibiotics for UTIs over the years, what are the longer-term risks like resistance, and how do you factor that into future treatment plans?
I'll say this probably a million times. I'm an antibiotic steward. Okay. So most UTIs, how I factor it in is I tell the patient, listen, we're going to do things differently probably than what you have been experienced, which is I have UTI symptoms. here's some antibiotic, knee jerk. Maybe you get testing done, maybe you don't. Maybe they call you back with the testing result, maybe they don't. I see this all day long. Somebody, recurrent UTIs, half of them have no idea what the results are. Okay, we're doing things differently from here on out. Every unique episode, we want to get data, and that means I want you to get a urine test done, all right, whether it's a urine culture or a urine PCR test, okay, as much as possible. And this is going to sound to some of the viewers' ears, I prefer to wait for the results before I treat. Why do I do that? Then I know exactly what the cause is and what antibiotics work or don't work for it, because these tests don't just give us a cause, they give us a resistant, and susceptible panel. And especially if you've been exposed to multiple antibiotics, you probably are resistant. You probably have a resistant strand already. So I don't know what that resistance is unless I have the data. All right. Now, I'm not cruel and unusual. I've had recurrent UTIs myself. I treat the symptoms with non-antibiotic mechanisms. Okay. So there are drugs like prescription phenazopyridine. Okay. There are patients who swear by things like Urogesic Blue and Urabel or Cystex or whatever. And I'm like, take those liberally, do what start those immediately, even before you do the urine test. But this is how we're going to do it. Symptoms are controlled. Ideally, we get data, we treat according to the data. We minimize overexposure and growing resistance and gut issue, and minimize, other side effects like gut issues and yeast infections.
Miriam has a question coming off of that, and the culture testing. What do you do if you already have resistance?
Well, every unique UTI may have a unique resistance pattern. So just because you have a history of an E. coli UTI that was resistant to Bactrim, let's just say, or a trimethoprim sulfametazole, that doesn't mean you're always going to be every UTI is now going to be resistant to that going forward. Believe it or not, microbes can devolve. Okay, they evolve and they can devolve. Okay, so again, we have to treat every unique UTI episode as a unique one. And I've seen this in myself. So like, I've had one UTI that was resistant to cephalosporins and Bactrim. I was so heartbroken. I was like, oh my God, multi-drug resistance. Here I am. And then the next time it was susceptible to cephalosporins. I was like, yay, So we treat, what do I do if they're already resistant? If they're already multi-drug resistant to like every oral option, then they're getting referred to infectious disease, because now they need IV antibiotics for a UTI. And let me tell you something, what's worse than a recurrent UTI is a recurrent significant multi-drug resistant UTI. That is now it's a whole ordeal.
We've dropped the term recurrent UTIs quite a bit so far. And there's a lot of talk online about biofilm and embedded infections. From your perspective, what does the science say, and how might that change how you treat recurrent UTIs?
Okay. I get asked this so much. So let's first of all make sure all our viewers know what recurrent UTI is defined as from the medical perspective. From the medical perspective, it's defined as 3 or more symptomatic culture, and I'll put in parentheses because it's really culture proven, but this was made before PCR. Urine PCR testing was like becoming more available, I would say, or PCR, but some sort of hey, this is the organism, positive with symptoms, 3 or more symptomatic culture proven UTIs in a year, or 2 or more in 6 months. Okay. That is the definition of recurrent UTIs. Okay. 2 key factors: symptoms and proven. Okay. Now, embedded UTIs, this is not a medical term recognized to date. Okay. This is a term that has been used in medicine. This is a term that patients know very well through patient communities and message boards and and blogs and stuff like that, but it is not a medically recognized universal term. We do have evidence, both in animal and human data, that bacteria, especially E. coli, which is the number one cause of UTIs, can either get into the cells of the bladder, like, and form these what we call intracellular communities. Like, imagine, like, we're so invaded, like, get into these cells. We have that data. We have data that we know that bacteria can form biofilms. So, like, a film on the lining of the bladder. I tell patients, imagine it's like squatters, okay? And so what happens is what we think is happening, I should say, because we don't know for sure, the pathophys, because we've seen these things exist in both symptomatic patients, like, ouch, I have symptoms, and those that have no symptoms. Okay. So why do some people have symptoms, some people don't? We don't know. But we think that these can hide from antibiotics, routine antibiotics, and then reemerge. And it may be a cause of why some people have what we call persistent UTIs, or even sometimes like UTI symptoms that might not be on routine culture. We don't know what to do with this, though. We have some data. It's not like it's hokey pokey. But we don't know what this means clinically. We don't know the clinical relevance in each patient. We don't know how to address this. Right now, there is, as far as I'm aware of, no major medical society that's endorsing this to do this treatment for an embedded UTI. And how do we prove this even? How do we even prove it's an embedded UTI? Like, what makes an embedded UTI? You know what I'm saying? So, do we give this patient antibiotics for months or years? Okay, we're balancing that with the risks of resistance and side effects and stuff like that, which have a growing issue with antibiotic resistance already, because we overprescribe when patients don't need it. So how do we balance that? And I don't have the answer. Sorry, that's the answer.
On the inverse of that, what happens when someone has all of the classic symptoms of a UTI, but their urine tests are coming back negative or inconclusive? How should that person advocate for themselves in those situations?
I'll answer the last part of the question first and then answer. So how should you advocate for yourself? I think whenever you're trying to advocate for yourself, I think trying to put your symptoms in plain language, okay? When patients come in and say, I feel like I have a UTI. Well, I don't know what that feels like. Maybe I don't know. I need you to tell me exactly what you're feeling. What do you feel? And I'm telling you, when you ask patients, well, what do you feel? You may get a varied response. And then that may actually change what you do. So I make my patients say, well, what is it? Pretend I don't know what a UTI feels like, and you're describing it for me. So that's what I want you all to do to advocate yourself. I feel stabbing pain when I urinate. I feel burning at the end of urination. I feel a constant awareness of my bladder and an urge that feels like my bladder is sitting like above my pubic bone. Whatever, I need you all to try to verbalize it explicitly. I feel a stabbing in my vulva. I feel sometimes you'll get weird things like I feel an itching in my Some people are like, I feel tingling in my toes. I just need you all to verbalize exactly what you are feeling. Don't come in and say, I feel like I have a UTI. No, I feel like I have these things happening in these parts of my body. Here, I can point here, all right? And tell them that's the first thing, is to characterize it very plainly. And two, to explain how it is affecting your quality of life. Because of these symptoms, I have missed work. Because of these symptoms, I can't sleep. Because of these symptoms, every time I pee, I cry. Whatever it is it's doing to you, okay? We need to understand the impact to then be able to be like, oh, well, damn. Excuse me. Well, people say some certain things like, well, damn, okay, well, that's, man. So those are my two things. Okay. Sorry for these long-winded answers. Second, the first part, is what do I do? Okay, if a patient comes in, classic UTI symptoms, it hurts, constant urge, yada, yada. Classic UTI symptoms, I would say, are it hurts to pee and frequency, especially if frequency is coupled with small voids and you feel like just like a near constant feeling or, it comes back. Those are classic. You may or may not see blood in the urine. So anyway, classic ones, we do a urine culture. That's the gold standard. It comes back negative. But gosh, I feel all these UTI symptoms. And assuming by the time that this culture comes back, they still are symptomatic. Okay, because sometimes they'll be like, well, the symptoms are gone. And then I'm like, okay, great. Okay, great. We stop there for now. But the symptoms are there. Then I do a urine PCR test. Okay, because a urine PCR is different than a culture. A culture grows out the organism in a petri dish, if you will. A urine PCR is looking at genetic materials, looking at like DNA and RNA, okay, of several organisms. A urine PCR includes organisms that a culture cannot. There are certain organisms, ureaplasma, mycoplasma, okay, that can cause UTI symptoms that a culture will never, ever be able to do. I include chlamydia and gonorrhea in that UTI PCR test typically if I can, just to rule that out. But I love a urine PCR test this is like the perfect scenario for a urine PCR test.
We have a question from someone on Instagram. They want to know, if you had a crystal ball, how long before the UTI vaccine is available in the US?
I mean, considering funding for women is like, oh no. It's in shambles. Considering funding for women is in shambles. I think the US, we got some time. I had a crystal ball, 5 years. Sadly. Yikes. Sadly. Yeah.
You're laughing that much.
Yeah. The moment that UTI vaccine hits the United States, I'm going to be on the street with a sign. Yeah.
Another question. This one's from Margie from the Uqora Collective. She says, an older adult in our community was told they have a UTI based on testing, but they don't feel like they have any symptoms. Is that very common? And how do you decide when it actually needs treatment versus when it's okay to just monitor?
I love this question because it's important for the public to know. There is such a thing as asymptomatic bacteriuria, and that is not the same as recurrent UTIs. What is asymptomatic bacteria? Asymptomatic means no symptoms. Bacteriuria means bacteria in urine. So it is literally a person with no symptoms but positive bacteria in the urine. Just exactly what is being described here. They had what I presume is a culture. By the way, y'all, the only way you can see the named bacteria in a test is a urine culture or PCR. These urine analysis don't do that. Okay, so if they tell you that day, you go to the urgent care and ER and they tell you that very hour, that day, oh, you have a UTI, please know that they are basing that on a preliminary test called a urine analysis, and they have not cultured or done a PCR because neither of those come back that dang fast in this world right now, okay? In order to prove, and that is a prelim test that is not diagnostic, that is not something you can hang your hat on. I've seen urinalysis look suspicious and all the testing negative. I've seen urinalysis look fine and testing positive. So please, if you're somebody listening on this right now and you have UTI symptoms and you go to an urgent care ER, please tell them, I want you to run a culture or urine PCR. My doctor said run or just get on my UTI. Yes. Listen, I'm empowering all of you right now. And you can, even if your doctor didn't say this, but I'm y'all's doctors today. Okay. Said to get a urine culture or PCR, and I don't care what that urinalysis says. That's what my doctor wants, okay? And they need to contact you back with the results. Okay, anyway, I'm diverging. So anyway, Sorry, you see how passionate I am. So some people have positive bacteria in their urine and don't have symptoms. And especially in older adults, the older we get, especially older women, we're more likely to have asymptomatic bacteriuria. In fact, 25 to 50% of older women have asymptomatic bacteriuria. So it's extremely common. Okay. Especially, we believe it's more common in like older community type settings like that. Okay. We do not recommend treating asymptomatic bacteriuria. That's the biggest thing I need y'all to know. Stop. If you are somebody who has no symptoms and your doctor's checking you and it's positive and they're giving you round after round of antibiotics, but you have no symptoms, stop the madness right now. Stop the madness. You are not somebody who has recurrent UTIs. You are not somebody who needs all those darn antibiotics. The only thing that's going to do is screw you when you have a real symptomatic UTI and now you have resistance. Okay. We do not treat asymptomatic bacteria. There are only 2 exceptions to that rule. One, during pregnancy. When you are pregnant, they will check your urine a gazillion times. Why? Because untreated UTI in pregnancy can cause complications of the pregnancy. So that is an exception. During pregnancy, you might not have symptoms, and we know that actually asymptomatic bacteria is more common in pregnancy. You will get treated, and that's appropriate, okay? Second exception, your urine must be sterile for an upcoming surgery. So let's say you're getting your knee replaced or your hip replaced. Most likely your orthopedic wants your urine to be sterile. So they may treat you even if you don't have symptoms if your testing comes positive. Or if you have some sort of specific urologic procedures, okay? There are plenty of urologic procedures that we want the urine sterile. If I'm treating a stone, if I'm going after and blasting a stone, I 1000% need that urine to be sterile. Okay. So those are the 2 exceptions.
I think you're on mute. I can't hear you.
Can't hear you. Good. I'm glad it's not.
Working snake, forgive me. We've talked about UTIs, or we're talking about symptoms a little bit longer. UTIs are common, especially in women, but sometimes they can turn serious. What are the red flag signs that mean someone should stop trying to manage it at home and seek urgent or emergency care right away?
Yeah. So we can't predict completely who this will happen to. There are certain high-risk individuals potentially that we may know. Somebody who's immunocompromised is probably at higher risk. Somebody who has a anatomic urologic abnormality, like they have a known blocked kidney or something like that, or like some congenital abnormality, may be at higher risk. There are other examples that I'm blanking at the time, but for the average viewer on this call, an average person, they're probably at not high risk. And so when do they say, ooh, I can't wait? Because as you heard earlier, I don't knee-jerk antibiotics. We try to wait to see. And I have like extremely few, like I have very few patients, very few, less than 1% going from UTI to hospitalized infection. Okay, fortunately. But things that would make you, common sense stuff. I would say if you are having a fever, especially if it's a high fever over 102 or higher, probably not your basic UTI. Okay, your basic bladder infection that's in your bladder usually does not cause a fever that high. So if it's 102 or higher, it might be going into your kidneys. I would go to an urgent care ER. Okay. If you are having a lot of pain, especially a lot of like what we call flank pain. Okay. Some people with classic bladder infections will get some back pain. Oftentimes it'll be like both sides or mild, but if it's moderate to severe pain on your flank, might be a sign to get checked out by the urgent care or ER. If you're throwing up, might be a sign to get checked by the ER or urgent care. Certainly, if you are mentally like lost, like your consciousness or confused, mentally confused, altered, not making sense, go to the ER. Okay, don't even go to the urgent care in that sense. Go to the ER. If your blood pressure is running low, if you pass out, I mean, some of these are really common sense stuff. Yeah.
We are getting a lot of questions about a very complex, common trigger for a lot of folks: sex. Let's talk about it. For people whose UTIs seem to be triggered by sex, beyond the usual advice like peeing after intercourse, what else can actually make a meaningful difference?
So again, became a recurrent UTI patient myself at the age of 40, and the trigger was sex, period. So I know this is well documented, and it doesn't matter. First thing I tell patient, it really doesn't matter. It's not you or your partner's fault. It's not that your partner's inherently dirty or you're dirty. It's just the mechanism of something penetrating going into our vulva, into our vagina, bringing kind of bacteria hitching a ride and getting into the urethra. Peeing after sex is not a bad idea. It's a completely benign thing to do. If you can do it, do it. If you can't do it, do not stress and force yourself to, because we actually have not studied this mechanism and we don't have the actual data that says that it works. Like, we haven't done the data. We just suspect it. Again, it's totally benign thing to do. I'm not poo-pooing it, but I also tell my patients, don't stress about it if you can't, okay? Please don't make sex this like sterile ritual. I don't think that that's an answer, because that hasn't been shown to work. So like some people are like, I make him shower and I shower and we scrub ourselves from head to toe and sand it, da-da-da-da-da. I mean, if you want to do that and that turns you on, have at it. But if that's taken away from your sexual experience and you're doing it in the name of UTI prevention, we don't have that data, okay? What are things that meaningful difference? So I'm going to get real with y'all for a moment. I tell my patients who are triggered by sex, I do ask them if they have anal sex or do anal play. And I say, I love it if you love it. I'm not against anal play, but I want you to do certain things. First of all, if you are using toys with anal play, I want you to have a separate set of anal toys and a separate set of vaginal toys. And I don't want you to mix those toys, okay? Because that could be directly bringing bacteria into your urethra, okay? I also, if you enjoy anal sex, I love it if you love it. No shame in that. I want you to end on the anal sex, okay? Don't go back and forth, okay? Now, 99.9% of my patients are already not don't fall into that category anyway, but just had to put that out there. But other things that can make a difference, this is the type of patient that if conservative measures fail, like vaginal estrogen or like methamphetamine, which is a non-antibiotic prescription medicine that can lower your risk of UTIs, then I am quick to pull the post-sex antibiotic trigger. This is the one scenario that I feel comfortable, like I have a low bar and feel comfortable giving prophylactic antibiotics to, because the data has shown that these patients have a much lower risk of resistance. They're taking an antibiotic just after sex. Usually I'll prescribe nitrofurantoin unless they have an allergy. That antibiotic currently has a low risk of resistance, and it typically works like a charm in most women who have post-sex UTIs without increasing the risk of resistance. Some of my patients will say, listen, I don't even take it after every single sex episode. I take it after like the real like headbanger ones.
After a weekend in Vegas. That's this.
Real nasty ones, you don't see. Good ones. Which is great. Yeah. So that's my approach there.
I do. So I saw a question pop up. So sorry to interject here, but I think this is relevant and in line with this right now. Is that, self-care and self-management in these situations, cleaning up with baby wipes, using a douche or some other, what they consider to be and are marketed often to women as a way to clean up and clean yourself and feel fresh. So how do you approach that conversation? Because I think sometimes what's put out there for women as far as like, this is what you should do to clean up, really does have some negative side effects.
Do not douche. Okay. You are increasing your risk of UTIs because you're wiping out a bunch of good bacteria. So douching is out. That is played. Cleansing wipes. I'm not totally poo-pooing those, depending on what they are. I think look at the ingredients and make sure that you are ideally your pH in your vulva is very important. Okay, it's important for UTI health and other things. So you don't want to throw that off, boo boo. So you just have to be discerning on what you use down there. All right. Not only that, our skin and the tissue there is different than the skin on our rest of our body. It's more sensitive. So you don't want to use a product that gives you symptoms that mimic a UTI because you're using some sort of wash or wipe or something that's now irritating and burning, okay, your vulva. So that's a case by case thing and product by product thing, but no douching. And I generally just tell patients, listen, we don't have the data that these things work. There are other things and maneuvers that we have the data for. I want you to enjoy sex. I don't want you to think of it as this major ritual. My goal is that you don't have to ritualize sex just because of your UTIs.
Continuing the talk about sex and products, Stephanie on Instagram asked, do certain condoms or lubricants increase the chance of a UTI?
Certain lubricants, maybe particularly oil-based lubricants, can potentially increase the risk of UTIs and vaginal infections. I am not against oil-based lubricants. Having said that, every person is different. I of all lubricants, tend to be pro silicone-based because it doesn't as far as we know, increase the risk of UTIs, and it lasts pretty long. People like oil-based because it's really slippery and it lasts a long time, which I love. I get that, but if you notice that you're using oil-based lubricants and you're getting UTIs, maybe that's something to switch. Certain condoms, as far as I'm aware, the only condoms that would potentially increase the risk of UTIs or if they include spermicides. Okay, because the actual spermicide can again disrupt your good microbiome that we need. Think of your microbiome as like a collection of good bacteria that are like fighters, okay, for the bad bacteria. So we do not recommend spermicide, and I don't even know if the condoms have, like, how many condoms have spermicide in them now. I was gonna say I haven't used a condom in years. So, but yeah, I don't think like lambskin versus latex has been shown to make a difference.
Another question from the collective here. For older women who have recurrent UTIs and have had side effects from frequent antibiotics, what does a safe, realistic, long-term prevention strategy look like so it doesn't become an endless cycle of stronger antibiotics? We've touched on it a little bit, but
yeah. First of all, are you on vaginal estrogen, sis? Because that is a must. Okay. That is a safe, well documented in science, long-term prevention strategy. Now, this is where I use my words very carefully with patients. There is nothing we can do right now in medicine to abracadabra say, do this, you'll never get a UTI again. I wish I would sell it for an affordable price, but get filthy rich if there was, okay? But there isn't. Like, if I give you antibiotics, I give you whatever, even the vaccine, what the correct word is risk reduction. That's really the better word, okay? Long-term risk reduction strategy. We want the risk of your UTIs to go down so that the frequency goes down, okay? So that the time between your UTI to the next is much longer. So there is well documented that estrogen reduces the risk of UTI by half, maybe even more. It reduces the risk of urosepsis by like 70%, reduces the risk of death by a significant amount. So estrogen, vaginal estrogen, is essential for women who are, in my opinion, 40 and up with recurrent UTIs, or pregnant women breastfeeding women with recurrent UTIs. The reason why I say breastfeeding is because during breastfeeding, your vaginal estrogen levels are low. So you are similar to menopausal vulvovaginal health, okay? And I will use vaginal estrogen in a woman in the 30s with recurrent UTIs, to be quite honest, because it is safe, okay? It is super safe. There is virtually no vagina or vulva that can't get it, okay, that is contraindicated. It is easy to use. With consistency, it can work. And I've seen it time and time again. So that's my first and foremost thing for women that are, again, like I say, 40 and up, and even some of my 30s. And really 20s even. I don't want my lying. I give it to everybody. Everybody gets it. And I also will consider methanamine. Methanamine is a prescription medication that essentially makes sure you're hostile to bacteria without being an antibiotic resistance. So it is not an antibiotic. Certainly, if you have a UTI that needs antibiotics, you wouldn't give them methanamine. The brand name is called Hiprex. So if you've seen that, it's the same thing. And I will do those strategies before I resort to long-term antibiotics.
Continuing our chat about long-term strategy.
Wait. I'm so sorry. I had to answer this question. Debbie, the question has to be answered. Thank you. I was like, my household. Wait, yes. Okay. Debbie, thank you for asking this. No, not this one. No, Debbie RW. If you can't take vaginal estrogen cream due to mobility challenges, that's the question. Yes. Debbie RW. Thank you for asking this. If you can't take, I'm glad my eyes saw it. If you can't take vaginal estrogen due to mobility challenges, is there an oral estrogen that can accomplish the same thing? Oh my God, Debbie, this is a great question. Okay. So, in general, oral estrogen and vaginal estrogen are not the same thing. They are not. Okay, not in general. Just point blank. If you're prescribed oral estrogen or transdermal estrogen patch, or you get an estrogen pellet or whatever, that's not vaginal estrogen, consider it not the same thing. Number one. Number two, you can get vaginal estrogen. It doesn't preclude you from getting vaginal estrogen on top of that. So let's say you're on oral estrogen patch or pellet and you get UTIs and I want to give you vaginal estrogen, take it. It doesn't continue to take your estrogen elsewhere. It doesn't matter. Now I'm getting to your question. Now, what do I do for my women who I want to put them on vaginal estrogen, but they can't manipulate their vagina? Okay. How do we make this possible? There are two options. So this is the great thing about vaginal estrogen. There are two options. Number one is called E-string. It is brand name called E-string, and it is a vaginal estradiol or estrogen ring that is replaced every 3 months. Okay. People who have a NuvaRing can kind of relate to this, although the NuvaRing is placed monthly. This is 3 months. So in my patients who can't navigate the vagina well on a daily or weekly basis, this is what my first go-to. And even if they have to see me every 3 months for me to do the replacement, I'm happy to do that. Okay. So every 3 months, they bring in their new NuvaRing, their E-string. I take out their old one, put in their new one. It's super easy. It's not a hard thing to do. That's number one. Number two, I just said oral estrogens are not the same. There, however, is an oral medication. It's not an estrogen. It's called a SERM, which is a selective estrogen receptor modulator. What the hell is that? That is a medicine that does different things to different estrogen receptors for a goal. So the brand name is called Osphena, OSPHENA. Osphamine, somebody help me if they know, is the generic name. But Osphena, okay, with a PH, is the brand name. It's an oral pill, take by mouth, but it selectively upregulates the estrogen receptors in the vagina. Okay, it is FDA approved actually for patients with pain with sex, which we would give another indication, which we would give vaginal estrogen to because we want the estrogen there to help with that. But I would use that for recurrent UTI because regulating estrogen receptors in the vagina without it doing other things. So those are the two ways to get vaginal estrogen in mobility issues. The other thing is it doesn't always have to be a cream. If they can do, if it's the cream and the creamy, application, if they can do an insert themselves, I'd go to that, or a suppository, I'd go to that. But again, if they can't navigate the vagina at all, it's E-string or Osphena.
I teased Hayden's question, so I want to go back.
Yes, go back. Yeah.
Is there any kind of probiotic you would suggest to help support urinary tract health?
This is where the medical person in me, I don't. I'm not poo-pooing it. As I say it, I don't poo-poo probiotics. Okay, they're benign for the most part, but we just don't have the robust evidence. I don't have enough robust evidence to like say take this, but I'm totally cool with it. People will say, well, can I take lactobacillus? And yeah, go at it, go for it. Okay. But if you're asking me about a certain type, that's as much as I can offer.
Another question. We're going to lean into the mental health side of it all for a moment. As we all know here, recurrent UTIs or chronic bladder pain can really impact someone's mental health, their relationships, intimacy. What would you say to someone who feels dismissed or they've been told like they're overreacting to their symptoms?
Number one, I would say you're not alone. Baby girl, you are not alone. Okay. There's a community. Find the community. Okay. So you can feel supported. Uqora has a community. I don't, my UTI, they probably have a community. Find the community. You got like, and I just have to say, I'm like, I think my UTI social media is so funny. So like, laughter is medicine. So if you want some like, just like, I just need to laugh about my pain away, like follow. Okay. For real. But anyway, you're not alone. Okay. Like, I want you to journal your symptoms and what it is doing to you. Okay. That is how you can better articulate when somebody pushes back and says, well, are you sure this is really happening? And you can be like, yes, I documented this. And then like, again, this is where going back to being specific about the actual symptoms as best as you can and use the words. You guys say down there a lot. And that's why I name my practice Down There Urology, because y'all say down there. And I tease and I'm like, your toes? No, use the word. In my vulva, if you didn't know, was the opening. But let's say you don't know. In the opening of my vagina, where the pee hole comes out. That's okay to use non-medical words, but be as descriptive as possible. Journal them and journal the impact that's having. I also do think that when you've had UTIs, you become hyper aware, right? You're just like, and so I don't want you to, as like easy as it is for me to say this, but harder to live this. I don't want you to wake up every day being on like, okay, when is the other shoe going to drop? Is this going to be the day that I feel like stabbing pain when I pee or whatever? Because your hyper awareness can, as we know, can increase stress and anxiety. And stress and anxiety is going to increase bladder symptoms. So when I tell a patient I want them to manage their stress and anxiety, either with psychotherapy or with self-care, I don't mean that I don't believe your symptoms. I believe your symptoms, baby girl. I really do. But I want us to, I see the impact on your mental health. Like, it's actually me acknowledging the impact on your mental health and addressing now the mental health aspect along with the clinical aspect.
I just want to pipe in real quick because I know we're streaming to the Uqora Collective. We talked about community, and for anyone who's feeling alone in this, please, there's a community of 40,000 incredible, supportive women who are going through similar journeys. It's on Facebook. I strongly encourage anyone to join. And just passing on Debbie's thanks to you, Dr. Milhouse.
Yay! You're welcome. You're welcome.
Thank you.
And thank both of you all, Uqora and my UTI, for having this passion for so many struggling women. Again, 25% of us, for having these spaces. You guys have no idea the lives that you are changing just by being able to like feel supported. There are plenty of women out there that are, don't have a good urologist in town or don't feel like they've been heard or, have no answers, that you guys are creating these these events, these spaces online. I'm not just saying this, like, y'all, by the way, just disclaimer, I'm not getting paid for this at all. $0. Okay. So they are not paying me to like hype them up. I'm literally thanking them for being spaces because I don't have enough time in the day with my patients to be that support system. So it is immensely, immensely empowering to have organizations, to have businesses like this that have made this a priority.
I'm going to throw one more last.
Thank you. And thank you too. You should also follow her on social media. She's a very good dancer.
100,000%. You're saying laughter is medicine. That is definitely a page.
Medicine. Yeah.
I'm going to throw our last question out there before we wrap things up. Nini on Facebook wants to know if an IUD could cause UTIs.
Like physiologically it shouldn't. An IUD doesn't change, isn't known to change your pH. So vaginal pH is important for UTIs. It's not known to change your pH. It's not known to change your estradiol or estrogen levels, which is important. It is local synthetic progesterone or progestin in the lining of the uterus, or if it's a copper IUD, which is non-progestin. So with that being said, no, most likely it is not. Having said that, this is purely like Dr. Milhouse anecdotal thing. I think I've seen where like even minor procedures in the that involve the vulva or vagina disrupt the like now trigger UTIs, and maybe there's some sort of microbiome disruption somehow that is occurring. Before you go and say, okay, I'm yanking out my IUD, I would absolutely maximize some of these other things that I have mentioned before you do that, because that's an invasive thing to do that is benefiting you, right? It's a great form of birth control. We actually love it in urology and sexual medicine because it reduces sexual medicine side effects. And there are things that like I would absolutely, and it's not guaranteed that your UTIs then get better. So there's no guarantee you can make by taking the IUD out. So that is, my answer to that. That's really sweet. No, Tishmi, I'm happy to be your doctor. Yeah. Oh, let's go. Yeah, I love it.
Dr. Milhouse, we're so grateful that you offered to spend an hour with us tonight and answer all of our questions. Folks, I'm going to drop her Instagram in the chat, and please go give her a follow. So much information, so much entertainment, edutainment, I think. Well,
I love it. Edutainment.
But again, just thank you so much. And I'm so glad that we were able to do this. Megan, thank you for your partnership. Everyone, those PCR tests we were talking about, my UTI. And again, if anyone
Doctor approved too, by the way. That's doctor.
Thank you.
Yeah.
If anyone has any Uqora product questions, again, our team was in the chat, but please reach out to them at support@uqora.com. They're ready to answer your questions as well. Dr. Milhouse, again, thank you so, so much. This was wonderful.
Thank you. It's been a pleasure. Thank you. We have to do this again. I really
Yes.
So little time. So many UTIs, so little time. We got to do it again.
Have a great night, everybody.
Have a good night.